thank you for the opportunity. We're really pleased to be with your group today. We were excited when this idea came forward because we recognize that we have a lot of folks who are either of retirement age or approaching retirement, and funding healthcare throughout retirement is something that people maybe haven't given enough thought to. And so we recognize that as an educational need among our members. And we see this session today as a pilot program. And depending on how we go and where your questions take us, we can refine this further, work with our educational team, and maybe come up with a webinar or a training program that we can make available more broadly. So this is really a first test. It is similar to content that Pat Haynes presented not long ago at the Middle Governing Bodies session in Baltimore. Okay, so with that said, let's go ahead and get started. I'll introduce myself. As you said, my name is Stu Beltz. I work in the benefits team here at the Board of Pensions. I've been here for 16 years. I have overall responsibility for the management of our healthcare program, our well-being or call to health program, as well as all the vendors that we use to support the fulfillment of those benefits, specifically Highmark, Optum prescription drug, as well as several other vendors like Cigna for EAP, Limeade for the call to health, Teladoc, Livongo, etc. I'm joined today by my colleague,
Sharon Castillo, and I've been with the board. I just had my 22nd anniversary.
Wow.
And I have had many roles here at the board. I started in what was considered plan operations, moved to healthcare, went back to the benefits team, and that's where I have lived for the last 10 or so years. I have responsibility for plan administration. So my work is really about the rules and the guidelines and the benefits plan. I also work very closely with church relations and plan operations to make sure everything in communication, so that everything in writing is correct. So I'm happy to be here and looking forward to it.
Gang, 1 minute if you give me one more technical moment. Folks that are watching, if you scroll up to the very top or the left-hand side of the picture row and you see a flat line and then maybe a blue box and then maybe a rectangle on top of a rectangle, if you click that middle box, you will just limit it to the speaker's face and you'll have more screen room.
You have done a lot of these, Susan.
Well, we try, and you can also change the size of that just by dragging it, but that might give you more screen space for those of you who are having there.
Susan, is that to the right or the left? I think you said left.
It is to the left. Yes,
Not
to
on
the
my
left.
screen.
Well, it's at the top left of the box that's now saying Wayne Yost.
well, and just so you know, our slides are not particularly dense. So you don't need the far right segment of the screen.
Okay. All right, go for it.
All right.
Thank you.
So as I said, we encourage you all to speak up as we go along. Retiree medical is an important topic for anyone contemplating or planning retirement. We're going to focus on medical options for members age 65 and older, where Medicare predominates the landscape. To be perfectly honest with you, prior to age 65, your options are expensive and relatively limited, since you don't have Medicare to be the primary payer. So, but even for those age 65, we'll be glad to talk about pre-65 options if you wish to, but we're going to keep our focus primarily on plans that come into play after age 65, where Medicare is the primary payer. So, like most things in life, one size does not fit all. we're going to try and cover the range of options in retirement so you can have a good understanding of the choices before you. So let's start with Medicare eligibility. Medicare is available for people age 65 or older, younger people with disabilities that are approved by Medicare, and people with end-stage renal disease. As you may recall, Medicare used to be offered in sync with Social Security, but unlike Social Security, the entry age for Medicare has not changed with changing mortality. I suspect that one of these years, the minimum age for Medicare may go up, especially as more folks continue to work past the age of 65. But for now, many of those working folks are relying on their employer coverage. So Medicare begins at age 65. You're actually eligible on the first day of the month of your, the first day of the month in which you turn age 65. So what are the ABCs of Medicare? That's kind of what it's built around. Medicare Part A, also known as hospital insurance, covers hospital inpatient care, nursing care, hospice, and home health care. It's premium free. It does not cost you anything because you've pre-funded it with Medicare payroll taxes that you've been paying while you've been working. That's the 1% that you'll see on your pay stub labeled Medicare. Technically, you do need to enroll in Part A, and you should do that 3 months before your 65th birthday. So for some of you, this might be your first piece of homework. To learn more about enrolling in Medicare Part A, go to www.medicare.gov. It's something you need to do on your own. There are no penalties for enrolling late, but you should do it ideally in advance. Now, Medicare Part B covers physician charges, outpatient care, durable medical equipment, and many preventive services. Part B requires that you enroll and pay for it. And Part B premiums are now income-based. They start at $135.50 a month, and that's the premium in 2019 for any individual making less than $85,000 in retirement. And premiums go up substantially as income rises. And one thing that we've learned in talking to clergy and other church workers is this is an expense that they often overlook. The fact that they will need to enroll, but the expense being that they have to pay for their Part B premiums really for the rest of their life, and that they are income sensitive. So for those who are fortunate enough to have a high income, those premiums can be significantly more than $135 a month. The next part of Medicare I want to tell you about is Part C. These are Medicare Advantage plans. These are private plans available from commercial insurance companies. By law, they must cover everything that's included in original Medicare, but they typically limit members to use network providers and hospitals in their local area. So these are most often local plans. If you travel outside of your local area, they typically only cover emergency care. They operate under specific rules established by the Centers for Medicare and Medicaid Services, which is frequently known as CMS, and they're generally lower in cost. So Medicare Advantage plans represent a lower cost option, but they do have limitations. They combine parts A, B, and D. I'll tell you about D in a moment, but that's the drug coverage. And they typically have some additional supplements provided by the carrier. In many cases, these plans are a good value particularly for someone who's not traveling a lot and who's satisfied with the network provider and the plan provisions. Medicare Advantage plans are a commercial replacement for traditional government-run Medicare. And the Advantage plans often include some form of prescription drug coverage, although some may be limited to generics only or just a short list of brand drugs. In some cases, they often include dental exams, fitness programs, and even hearing aids. Popular Medicare Advantage plans are offered by Highmark, by UPMC, Humana, and that's in the greater Pennsylvania area. Humana has a large market share nationally. Aetna has Medicare Advantage plans. Almost every insurance carrier is offering Medicare Advantage plans. So in fact, if you're nearing age 65 or you're over age 65 now, you're probably being bombarded at home with mailers from Cigna or Aetna or Highmark or whomever else with their advertising literature every day in the mail. I'm even getting some, I have to admit, I've recently turned 65, so I'm getting some spam phone calls and emails, and so they do manage to track us down. But the Medicare Advantage plans are out there. And finally, Part D is a prescription drug program. These were added in 2006 under the Bush administration. And this is your prescription drug coverage specifically designed for those covered under Medicare. In this day and age, prescription drug coverage really is an essential part of an individual's medical coverage. No one should be without it. With that said, Part D programs vary considerably. They're not all the same. Some just cover generics. Some have a very limited list of brand drugs. Some require that you use mail order for all of your maintenance drugs. Some require you to go to a limited distribution of pharmacies, etc. Part D plan, your drug plan, can be purchased separately, or it can be baked into a supplemental plan. In any case, it's an important feature to examine closely, to look at the cost of prescription drugs, as well as the inclusion of the drugs that you or your partner use. We're often asked if an employee is eligible for Medicare at age 65 and they're still working, why can't an employer or a church drop them from the board's active medical plan and let them take advantage of a Medicare plan that may be lower cost to them? Sharon?
Yep, so I'm going to talk a little bit about the reasons why this generally doesn't work. The first is legal. Federal Medicare and age discrimination employment laws prohibit an employer from treating an employee age 65 and older differently from its other employers. While these laws do have exceptions or exemptions for small employers with less than 20, our plan fundamentally assumes that working aged, and that's a term coined by CMS for those 65 and older in active service, will continue to be covered by the board's medical plan. That plan remains the primary payer during active employment. And that's because employers need to treat all employees consistently, no matter what their age. With that said, there are a few exceptions to these rules. Any church that issues fewer than 20 W-2s, and that's a lot of churches in our group, can apply for an exemption to Medicare secondary payer rules, allowing Medicare to be primary for Part A expenses.
Those are the hospital expenses.
They're the hospital expenses that you don't have to pay for. You paid for them all along. We do this because while it does not affect the employer's dues obligation or the member's out-of-pocket expense, it does have the potential of saving the Medicare plan, the medical plan, significant dollars.
So it's an example of good stewardship.
Absolutely,
Yeah.
Absolutely. Essentially, hospital bills are covered by Medicare, while all other expenses are still covered by the board's active medical plan. And Highmark adjudicates the claim in a way that ensures that the patient or the member would have the same cost share as if they were covered under our plan as primary. We are continuing to look at options for the working aged. As you might imagine, the size of that group is really growing. Many members are choosing to work beyond age 65, in some cases well beyond age 65. So for those of you who are moving into retirement, choosing coverage can be confusing and frightening. So let's move to some basics about medical plan options at retirement. So, and I'm going to repeat some of what Stu said because I think it's important. Sometimes it's just a different way to say it, or you know, just hearing something a second time, I think it just becomes clearer. So at the highest level, an individual needs to decide if they want traditional Medicare, which is Medicare A and B, or if they want that Medicare Advantage plan, the one that Stu was talking about, that have some of the extras, but certainly some restrictions. A good place to start is to look at the more traditional fee-for-service Medicare approach to coverage. And you need to realize that it doesn't cover all your healthcare needs. For example, the deductible under Medicare is high at approximately $1,300. It has no prescription coverage, and it doesn't allow for medical coverage while traveling overseas. So as a result of those gaps, most people will choose the Medigap or supplement plan.
And the purpose of those plans is to fill the gap.
Absolutely,
Okay.
to fill the gap, right. There are two key questions that each individual needs to consider when they're looking at these options, and it's what type of supplemental coverage do I want, and what I can afford, and how will I cover my prescription drug expenses. So in terms of supplemental coverage, there's lots of standalone Medigap plans that an individual might buy. In the past, they may have been referred by the alphabet A through N with no E, H, I, and J. Those letters are even changing for 2020, so I wouldn't get bogged down with those. All must conform with coverage parameters prescribed by CMS. They cover the copays and deductibles, but they cover the copays and deductibles not covered by A and B. So it essentially wraps around. They are age and regionally priced and vary from carrier to carrier. If an individual opts to purchase a standard Medigap plan, they must also shop separately for a prescription drug plan. Before you make a decision, you want to make sure that your prescriptions are covered. Many members who have enjoyed the benefits of our active coverage and want to continue a trusted relationship with the board simply opt to take the Medicare supplement coverage. While it does fill a lot of those gaps of Part A and Part B and does include broad prescription drug coverage, it may not be the most economical solution because the board's premium is $275 a month for an individual and $550 for a couple. I'll get into the specifics about the board's Medicare supplement plan in a moment, but let's talk about that Med Advantage plan one more time. So the Med Advantage plan could be somewhat like an HMO or a PPO. They generally impose rules around accessing services, and they most always rely on a network of local physicians and hospitals, and prescription drugs benefits may be limited. These plans also include features that may be attractive to you, for example, vision exams, dental care, hearing aids, silver sneakers, and that's just a few of the features that a lot of Med Advantage plans have. These features are not normally included in a Medigap plan or a Medicare supplement plan, including the boards. But keep in mind, if you choose a Med Advantage plan and want to come back to the board's plan, you need to sign a waiver at retirement and come back within a year. As you go through a retirement process, the plan operations team will walk you through that, but always consider that waiver. So how do you choose? Well, bottom line, it's really a personal decision, and one that unfortunately requires some committed research time. But there's a list of considerations that might be at least provide a framework for such decisions. Let Stu talk about that.
Okay, but before I do, I just want to reinforce one point that Sharon just made. With the board's Medicare supplement plan, we do allow members to waive coverage for up to 1 year. But if you want to come back to the board's coverage, you do need to come back within a year. Okay, so keep that in mind. And we do that really to protect the greater good of the plan. As you can imagine, folks would have an incentive to opt for an inexpensive plan if they didn't have health issues, but once they had a significant health issue, may opt into the board's plan. And that would be unfair to those who've been participating in the board's plan all along. So we need to protect the integrity of the pool of participants and not have it be subject to adverse selection. Okay, so as you assess your options, some things you certainly want to think about is health status would certainly be a significant consideration. What conditions do you have? Where are you getting treated? What providers, what types of providers do you see? What medications do you take? So certainly look over the coverage provisions of any alternatives you're considering to see if the network matches up with your needs as well as the coverage that's included. Cost, of course, is a significant role. For instance, there are Medicare Advantage plans we talked about that actually have a $0 premium. So you still pay your Part B, but there's no premium in addition to what's required for your Part B. These plans also may have low out-of-pocket costs. On the other hand, there's restrictions. There's typically no coverage if you travel overseas and limited to emergency coverage elsewhere in the U.S. Then there are the Medigap plans, independent of the boards, and those are worth looking at. Those can be subject to a medical review, and pricing may vary depending on your history. Pricing certainly varies depending upon your location. So Medigap plans are certainly an option. And both these plans are not likely to have the same design features. So it's likely that there would be some significant network restrictions in the Medicare Advantage plans. Also, as I said earlier, some limitations to the prescription drug benefits. So these are some of the things that you certainly need to decide. If you're a snowbird or a frequent traveler, it would be important to understand any coverage restrictions out of your home area. When you enroll in a Medicare supplement plan, and you have the option to do that every year, typically in this time frame, in the October-November time frame. So you can change plans every year, but once you make an enrollment, you're in that plan for the duration of the year. And of course, you want to consider service support should you need it. Are people there to help you and to explain your benefits and to direct you to care or special services as you need them? Most shoppers focus on what is covered and what it costs, and that's a good place to start. The good news is, as I said a moment ago, you're not locked in for more than a year. You can make other coverage choices as needs change each October and November during the open enrollment season that's underway now.
And while we're absolutely not here to sell the board's Medicare supplement plan, I do want to spend just a few minutes on some of the key components because it is different than most standard Medigap plans and Med Advantage plans. So let's talk about who can enroll. First, and not surprisingly, you must be 65 years of age or older, actually retired, that's key, and enrolled in Medicare's A and B. You also need to be transitioning from the board's medical plan as an active participant. In other words, be an active member of our medical plan at the time of retirement or a terminated vested member. And a terminated vested member, if you leave to maybe be on a spouse's active employment, you need to sign the waiver at your retirement. So that waiver is very important. And you need to have at least 5 years of active participation in our plan and meet what is known as the rule of 70, which is your age and your years of plan participation, and that needs to equal 70 or more. The Medicare supplement plan was designed to resemble the active coverage, not necessarily duplicate it, just resemble it. So there is a deductible for medical costs. Currently it's $305, and there is a maximum out-of-pocket exposure. Currently it's $2,435. They're the 2020 rates. They were a little lower for 2019. There is no deductible for prescription drugs, and there is a prescription drug maximum, which is $2,500, and that's per individual.
Sharon, do the copays for prescription drug resemble the active plan?
They do. They do. The plan design is almost identical, including the formulary and the formulary list.
So you shouldn't expect a change in the cost of your prescription drugs if we're currently using them.
That's right.
Okay.
The board's plan does provide coverage while traveling outside the United States. And as Stu just mentioned, the drug benefits are essentially the same as if you were an active member. Highmark is the administrator of our medical claims, and Optum continues to be the administrator for prescription drug benefits. Of course, the feature that many of our members really do appreciate is they're still supported by service here at the board. And then the cost of the plan is really determined by actual experience. It is essentially a self-pay program funded almost entirely by the retirees who participate. Our costs have been really stable over the years, but there's no promise around that stability. We are heading into our 3rd year of no increase. And again, I'll mention it's $275 per member per month. If your pension check allows it, that's taken directly from your pension check.
So, and let's be clear about this. So whether you live in a high cost region or a low cost region, the premium for the board's Medicare supplement plan is the same. It's $275 a month.
That's correct.
If you're shopping online at Medicare.gov, you'll see that your cost will vary by your zip code for many of the supplement plans and Medigap plans. But that's not the case. Our price is one size for everyone in the community.
Yep.
Okay.
So maybe you were really hoping for an easy and prescriptive answer to your question, what should I do? I have friends and family who call me all the time and ask this very question. And of course, we have some members who ask the question as well. However, we wish we could answer it, but quite honestly, we can't, or at least we shouldn't. What we can do, however, is to point to good resources to launch your journey. And in particular, Medicare.gov is a great resource, and I suggest members should spend some time on it. It's rich in content and surprisingly easy to navigate. It will ask you for your zip code and then provide all the plan options and costs in your region. As for pieces developed by the board, here's 2 of our latest. One is Choosing Healthcare at Retirement. This is a really good piece that goes through almost exactly what Stu and I just talked about, the ABCs of Medicare, and then talks about the board's plan. And also, if you want specific detail on our Medicare supplement plan, the guide to Medicare supplement is a really good explanation of all kind of some of the details we weren't able to get into. And then finally, as I mentioned, the support that the board has. We have highly skilled and knowledgeable human resources at the board. As
People.
People, actual real people. As with all things, they really thrive on their ability to provide customized and personalized service support. Although they can't answer your question, which plan should I pick, they can point you in the right directions. Your best counsel, either to yourself or to seeking anyone in your church that is seeking counsel from you, is be first, investigate options early and often. Carefully assess your needs and use all the available resources. It's our pleasure. If you have any questions, we'd be glad to answer them.
Looking for some hands to raise.
I'm curious if people have started to do the search on their own and what their experience has been.
Y'all, you are muted, so unmute yourself. Judy Black, I'm going to unmute you. Go ahead, Judy. Judy.
Medicare, Medigap.
You guys have two computers on? We're not hearing, Joy, we're not hearing you, you're muted.
That's right. And that's what
Let's have
causes
two sounds on.
Judy. What is the maximum out of pocket?
For the board's plan, if you're asking for the board's plan, it's $2,435.
That's the medical maximum.
That's the medical maximum, and the prescription maximum is $2,500.
So, may I ask, if you were to compare the board's plan to the ABC through N Medigap plans, what would it be most comparable to?
You know, we have always compared ourselves to an F plan. I understand F plans are going away next year, so I haven't sat and really looked to see, to go down the list.
Okay.
If you go on Medicare, it will give you a chart and
Right.
line them all up, and it go through and see what what fills in a lot of one of the things is our deductible's lower, so we are essentially, the board's plan takes care of some of the deductible. Some plans don't do that. They only have they allow the Medicare deductible to stand alone.
Okay.
So this is Sue Wonderland following up on that. It'd be like an F plan, is the board's coverage 100%?
No.
No, it's 80% of what Medicare does not cover.
So an F plan would have covered 100%, correct?
We don't have the F plan terms
Okay.
in front of us.
No, but it's an 80-20 split of what Medicare won't cover.
Correct.
Okay. Dennis, go ahead.
Is it possible for you to back up to the previous slide around eligibility for the Board of Pensions supplemental plan?
Yeah.
This is a question about eligibility. What you've addressed seems to apply to the member. What is the eligibility criteria for members dependent on a spouse?
It follows the member. So if the member meets the rule of 70, then the spouse would meet the rule of 70. So for instance, if your spouse was on her own plan, you were the only person in the plan, at your retirement, if you've met the rule of 70 and any other eligibility issues, you're in A and B and active medical plan, she could come into the plan at that point with you.
Okay, the spouse would still need to be 65 or older.
Yes,
That's right.
yes.
Okay,
Yeah,
what
right.
if they're not? Would they be able to rejoin the minister member in the plan later on?
Can you rephrase that question? I want to make sure I understand that.
What if they are under 65 at the time the member retires?
Okay.
Would they be able to come back in to this coverage?
So at that point, they could go on medical continuation if they needed coverage. If they didn't need coverage because they were covered by an active plan, they would waive coverage just like a member would. The member could go into the med sup plan. The spouse would waive coverage until they turn 65. The time they turn 65 and enroll in A and B, then they could come into the med.
Okay, thank you.
You're welcome.
And would that also apply to, say, if the spouse, the pre-65 spouse got coverage on the exchanges, the state exchange?
If it was a yes, qualified health plan.
So they had independent coverage on their own, but then when they turned age 65, they could join the minister member or the plan member in the supplemental.
Right, as long as they had coverage. They had a qualified health plan.
Good, thank you.
Judy, go ahead. Go ahead and unmute yourself. Judy Black, you trying to unmute you. Go ahead, Judy.
This is Joy.
Okay.
Oh, so sorry.
You guys
My-
have no sound on.
Pardon?
You must have two microphones on.
We have one off and one on.
That doesn't matter. Okay, just go. I'm sorry. We probably can't fix it right now.
Is older than I? How does that work?
Okay, if the spouse is older than you, then when you so I assume they have coverage. So if you're in the active plan and they are in the plan with you, they would just, sign up for Part A, just like we had talked about. But they would still be protected by the active plan. When you retire, so all eligibility follows the member. So when you retire, then they would be able to come into the med sup plan. The med sup plan is not offered independently while an active member is in the plan.
And that's per federal law. The employer plan is primary. Yep.
Joy, do you
Susan,
follow up on that with anything? You have a follow-up question?
No, thank you.
Susan, I wanted to try and illustrate what you mentioned a moment ago. In many cases, with the board's Medicare supplement plan, there's a $305 deductible. And once the member satisfies their deductible, Medicare will typically pay 80/20 for most services. So say there's a hospitalization, and for illustration purposes, let's say there was a $1,000 bill from the hospital. Medicare would pay $800. The remaining $200 would be automatically submitted to Highmark. The member doesn't have to do anything. And then Highmark would pay 80% of that $200, leaving the member with an ultimate responsibility of $40, I believe. Yes. Okay. So the board's plan is relatively rich in its coverage, but it's also relatively high in its premium at $275. Now, in some markets, that's a real value, but in other markets, it's not. And that's why it's really important to look at your local pricing.
Well, Stu, thank you for that. I think that with the numbers and all, that's really helpful. But the other piece, regular med supplements do not necessarily have the drugs. you'd be paying an additional, you'd be also getting an additional plan. So that has to be figured into it.
You're
Absolutely.
right.
Right, and those drug plans vary radically. Some of them are really skinny with even just sometimes very limited number of generics.
Yep. You, on Medicare.gov, you can, when you were selecting a D plan for the drugs, you can actually list the medications you're currently on, and it will give you coverage that, or the plans that actually pay for those drugs. Now, the issue is that, you know, that can change in a month or two if you go to your doctor and they put you on something else. But you can do that research if you're on some type of maintenance medication.
Could you go back over the small church opportunities when someone is working over age 65? I think that's something that we need to hear, that some of us for ourselves and some of us for the work that we do with congregations and pastors.
Sure, I'd be glad to. So if there's an active member working over age 65, and the church or the employing organization has less than 20 W-2s, it doesn't matter how many hours.
Saying less than 20 employees.
Right.
Actually, but remember, it's not full-time. It's anyone to whom they've issued a W-2.
Right, and that's what I was just going to say. So yeah, no, that's fine. So it doesn't matter whether that employee has only worked, you know, 5 hours a week for the entire year. That would be considered an employee. So less than 20 W-2s, they can apply for a small employer exception. The package is on our website, pensions.org. And what that does is the member signs up for A, and he or she should, since it's free to them, it's something they've paid into all along, sign up for Part A, and then the claim gets adjudicated first with Medicare, and then the board will make sure that the member is not paying any more than they would if they were in the active coverage. It doesn't get into those office visits or lab charges or anything that would be covered under B. It's just expenses in A, so specifically hospital.
So in other words, it doesn't save the employer and it does not save the employee any out-of-pocket costs, but it does help the plan because Medicare becomes the primary payer for hospitalizations. And of course, hospitalizations often the biggest component of cost, particularly for folks over age 65.
But it doesn't impact dues.
No,
It does not.
Okay, thank you. Who else? Anybody?
This is David Euler. From a little bit of a different angle, and I don't want to overgeneralize with dollars, but I am concerned with the pastors I work with, ages 60 to 65 especially, who are not realizing the enormity of the cost. Now, and again, this is a generalizing, but if, for instance, just give an example of a couple who is the same age within a few months of each other, using this coverage, of course, there's the Medicare, $135 a month, $275 a month for each of them. And then if there are the co-pays for, particularly for medicine purchases, well, even those first two, so that's over $400 a month times 12 is $5,000 roughly, times 2 is $10,000. The medicine purchases pretty quickly could get someone up, or a couple up to $12,000, $13,000, $14,000 range. Am I doing the math correctly?
Yes, you are.
And I think that is pretty far off the radar screen, even though I try and have these individual conversations with couples, and they are stunned by that. In the last few months, I talked with two pastors I'd talked with before. They both retired. They both came back to me within 6 or 8 weeks and said, this is costing a great deal more for medical coverage than I realized, even though I know they had accessed Board of Pension information, and I know I'd had conversations with them as well. But the reality hit the road when they were actually retired.
Right.
And so I guess I'm urging, it's not so much a question, but I'm urging the board to talk about this and maybe talk about practical examples, realizing everyone's situation varies. I recognize all of that. But I think it's pretty easy to, with medicine purchase particularly, to run an additional cost that might not be understood when they talk about the basic monthly Medicare fee and the basic fee for the other parts of Medicare coverage.
Right, you know, that's a really good point. And we're taking notes. And so when we go back to our education team to say, we really believe this pilot really worked and that we should really be getting in front of more and more members, especially that 60 to 65 age. So we'll put real live examples in there to make sure that we illustrate that. That's really important.
You know, thank you, David. We can look at the claims history and see what the average member pays in terms of prescription drug and office visit and other service co-pays, and add that on top of their monthly premiums as well as their Part B premiums, and it is quite significant. And this is a group that's been insulated. You know, our plan is, our active plan is fabulous protection, but it also protects the ministers from paying premiums throughout their work life.
Right.
So now suddenly they're hit, and you're right. I think it catches many of them off guard.
I think that would serve the pastors or the people in the program very well if the reality could be spelled out as much as possible.
Mm-hmm.
Okay, that's a good point. Thank you. Anything else?
Anything we forgot?
It sounds awfully quiet. I'll ask another question if I might. You touched on international travel. And remind me again, what the Board of Pension offers does provide international coverage.
Correct.
That's right.
Those who choose to go another route, some of those do not provide international coverage. Is it possible for people to purchase short-term, you know, I can imagine a number of Presbyterian pastors who will, in their early retirement years, you know, travel to Europe for 2 or 3 weeks or whatever it might be, but not spending 6 months a year overseas. Are there, and you probably can't speak for other programs, but is it possible to do that for those who say, boy, I'm not going to go the Board of Pensions route, but I also need to figure out how to cover myself for international travel occasionally?
Right. Yeah, there are short-term plans that you can purchase independently. A lot of time it's at the time that you're making your reservations that you can do that. They're usually very inexpensive, but they do protect people who would have an issue while they were away.
Okay. Thank you.
You're welcome.
Typically don't cover evacuation. You know, that typically the person would have to stay in their resident country for treatment.
This is Joy again. Oh, golly, sorry. I echo David about information. 80% of our pastors are baby boomers. I don't understand about the other Medicare letters, the ones beyond D.
Oh, the other Medicare letters, is that what you were asking? I believe that's what you were asking. Okay, so you know, the best way to do it is to go on Medicare.gov there's a button on the left, I believe, that says compare plans, and that has a full chart, and it goes into all these different plans, what a C is considered, a D is considered, and it goes all the way up to N. But, and some of it is exactly what Susan was talking about, how much of the after Medicare is paid. So when Medicare pays their 80%, does the plan pick up 80%? Do they pick up the deductible? And there's probably, I don't know, maybe 30 different. On the left-hand side, one of them is international travel, and for most it will be no. So the board's plan doesn't line up perfectly, but it's somewhere between like an F and a J is what we've really said. But I think it's best to look at that chart. It's hard to explain the individual, what plans are the different pieces of each plan.
Anybody else? Going once? Going twice?
Susan, is this a general question or specific question on what has been presented so far?
Anything you want.
Sure.
Okay. Yesterday, in one of the groups I'm in on Facebook, they were raising the question, why did the board request a marriage license after the member had been in the plan for many years?
Did they ask that when the member was retiring? Is the member going through retirement? Do you know?
No, it was the member had just completed their, I forget what they called it. They were still in active service.
Okay. Still in active service.
Well, unfortunately, marriage is not in perpetuity, and people too get divorced and marriages end. So,
But there would have had to been a trigger for a reason for us to go out and request it. There was a time about 7-8 years ago that we went back and actually asked everyone to substantiate their marriage or their dependents, and now we require it in order to enroll someone. Susan has my contact information. If you wanted to send me the member's name, I'd be glad to look why we requested it. There would have had to been a specific reason. There was not that the board has gone and asked everyone for it. We did that several years ago, as I said, when we were doing some cleanup.
Okay, thank you.
You're welcome.
Anybody else? So we have recorded this, friends, and we'll make it available to you to share. What would be helpful, Stu, as we go on from here? What would be helpful for you guys? Would you like to hear questions that emerge would you guys like to hear questions that emerge as we go away from here? What can we do, Sharon?
I think that would be helpful. So there may be something that doesn't come to mind immediately, so that if questions emerge in the days and weeks ahead, perhaps if they could funnel them to you and you to us, that would be fabulous.
Yeah, especially if we can make the education program a little bit better. This was really our first stab at it, and we hope that it satisfied what you were looking for.
I think we see some things that we can improve.
Absolutely.
So
I think part of what I experienced, and I also know because I know a lot of these folks, is we have folks that are really at Medicare 101 and folks that have done some research. So the moving parts are very strange, and the more you could help, even with the moving parts that don't necessarily relate into the Board of Pensions plan, but it would help us to see and understand, what are the letters? Is there a small, we could even pass out a small sheet or whatever, because we come with very different understandings of where we are. But I think you've helped us a lot, and you've helped us to begin to raise some of the questions that need to be raised.
super. That was really our goal.
Okay. The other thing that from my perspective, I would say really clearly as a clergy couple person is this is a huge shift moving from clergy couple status to individual people statuses. The additional benefits that clergy couples receive are wonderful, but it's not going to be the case. And we need to be able to articulate that for ourselves, but for others as well.
Absolutely. Yeah.
So I think we're in good shape, gang, and we appreciate the work that you do with us and on our behalf. Sharon and Stu, thank you very, very much. We'll send you the link too, so you can take a look at yourself as well.
Super.
Okay.
All right,
you.
friends, if you want to leave this meeting, to the lower right-hand corner of your screen, there's a leave meeting thing. And you can click on that. I'll wait till you're all gone before I end it in case somebody pops up with a question. But this has been really helpful. Thank you.
Thank you all.
Thank you.
Thanks.
Bye-bye now.
Is that the brand?
Yeah, I think we're,
Oh, look, there was a camera.
There was a camera up there? No, that was this camera.
you're on.
We're on.
Oh, okay, that's there. Okay. Okay, we're going to leave you too, Susan. Thank you.
You're welcome.
Thanks.
Thank you.
Bye now.